Well, it's Saturday the 17th of April and you are most welcome. Now I'm going to look at a few principles today that are going to affect the way this pandemic rolls out over the next few months. But before we do that, it's one of those sort of grim milestone days. So the official deaths have now exceeded 3 million. We know the real number of deaths in the world is higher than that, but it's always sobering when we see these official numbers. Now, in terms of the cases globally, there is a resurgence in cases. They're pretty well doubled in the last few weeks, so that's like February, March there. Cases are definitely on the up. Globally, we're talking about here. And as we know, deaths follow. Deaths aren't as high yet, but we see that deaths are following that oh so familiar trajectory now with the 3 or 4 week delay from the cases being diagnosed until deaths starting to occur. And most of this, of course, is new variant driven, that there are new mutations that are driving these increased waves around the world. So remember, these are global figures, global increase in cases at the moment. Now, Centers for Disease Control in the States, they seem to be communicating via email. So very strange. I spent a lot of time looking for this on the website. Couldn't find it. And I think this email to CNN, I believe it was, is the only source of this information. So strange way to go about your business, CDC, emailing CNN, but there you go. It's up to you. And this is on breakthrough infections after vaccinations. The bottom line here is the news is pretty good, actually. Yeah, pretty good. I think that's fair to say. Now, vaccinated people in the United States who've become infected, 5,800 people have become infected. Now, that sounds bad until you realise it's about 1 in 13,275 of those that have been vaccinated with 2 vaccines. Now, we looked at the data from the UK from the Tim Spector COVID Symptom Study app a few days ago. And we found out that without vaccination, the rate of infection was about 1 in 1,100. After the first vaccine, it was about 1 in 5,100. And after 2 vaccines, it was about 1 chance in 15,000. So this data from the States is broadly comparable. About 1 infection per 13,275 after vaccines. Stress, of course, this is at least 14 days after their final dose. So less than half than that after the first dose, but way less than that without the vaccine. So efficacy of the vaccine there proved really beyond, well, way beyond any question that the science is there. This is based on post-surveillance pharmacovigilance. But it is 14 days after the second dose, remember. Asymptomatic infections of those were found, so 29% of those were found to be asymptomatic, picked up by PCR testing. So even a lot of those were asymptomatic. Now, unfortunately, 396 did require hospitalizations. That works out at 1 person for every 194,444 vaccinated. And there were still some deaths. There were 74 deaths. That works out at 1 in over a million deaths. Now, why we're still getting these breakthrough infections, why we're still getting a few hospitalizations and deaths, of course, CDC is currently investigating. Maybe more cases to report due to reporting lag. So this is making the vaccine look as good as possible, really, because the vaccination figures are ahead. But this is based on 77 million vaccines given, fully vaccinated. The real number now, though, is well over 81 million. So it is moving on, but that's based on that amount of data. So very good levels of protection there. Chances of getting reinfected or infected are 1 in 3,275. So that is really good news. That's how well protected these people are. Requiring hospitalizations, 1 in 194,444. And if you bear in mind that maybe 5% of people needed hospitalized before who got infected, that's 1 in 20, isn't it? So what chances would you like to take? 1 in 20 of being hospitalized or 1 in 194,444 being hospitalised. I know which one I would pick. I'm going to go for that one. So this really is impressive real-world data based on the US vaccine rollout, based on 77 million vaccinations. Now, it is roughly what we'd expect from trials. So from trials, Pfizer BioNTech phase 3 clinical trials, 95% in preventing symptomatic disease. But of course, remember, some of these, 29% of these, were actually asymptomatics. Moderna 94%, Johnson & Johnson, Janssen 72%. But of course, a much higher probability of preventing severe illness and death. Now, characteristics of the breakthrough so far, what might it be that's predisposing some people to still get infections after they've been vaccinated? Well, the CDC email doesn't say this, but basically these are people that are having difficulty making an immune response, people that are immunocompromised for one reason or another. And of course, one of the factors in developing a good immune response is adequate levels of vitamin D, which CDC does not mention in their email. So if people have adequate levels of vitamin D, I would expect them to have a better immune response to their vaccine than people with low levels of vitamin D. Only one factor, there's others of course. People that are immunocompromised for whatever reason won't have as good a response, but they don't mention the vitamin D, which is surprising and disappointing. But 40% of the infections were in people over 60. Well, that's not too surprising, really. 65% were female, so slight greater difficulty in women developing an immune response compared to men. No obvious reasons for this at the moment. It wasn't really picked up in the phase 3 clinical trials, where markedly it was noted that in the phase 3 clinical trials, people over the age of 60 were developing a good immune response. So somewhat inconsistent there, but 40% of the over 60s isn't that high a percentage because a lot of people are over 60. So direct quotes from the email: CDC is monitoring reported cases for clustering by patient demographics, as you would expect, geographical location, time since vaccination, vaccination type or lot number, just in case there's any inconsistencies in the vaccine itself. I think that's very unlikely with the quality of manufacturing in the States. And SARS coronavirus 2 lineage, of course, which is almost certainly going to be a factor if there's a variant of concern with a phylogenetic lineage that could make it potentially more likely to avoid the immune system. CDC also continues to recommend that people are fully vaccinated should keep taking precautions in public places, like wearing a mask, staying at least 6 feet apart from others, avoiding crowds and poorly ventilated spaces, and washing their hands often. But of course, they did say that they can consider flying domestically recently, so a bit of a contradiction there. But basically, their CDCs are saying that normal precautions should still be employed, at least for the time being. But this is remarkably high levels of efficacy. So one chance in 13,275 of becoming infected after 2 doses of the vaccine. It's good. That's good stuff. Now, the H word wasn't really mentioned. That's the herd immunity word. But it's alluded to here. So this doctor from this medical school. Less transmission means through a breakthrough cases. So what he's saying here is that if there's less transmission as a result of vaccination, then there's going to be fewer breakthrough cases. In other words, that's kind of a way of saying that herd immunity seems to be developing without saying that herd immunity seems to be developing. But we do know from other data that herd immunity does seem to be developing, but we're not there yet for the States. The data from Israel is good. The data from the UK is very promising indeed. Tim Spector certainly thinks that herd immunity is starting to kick in now in the UK. Don't get complacent at all. There's still a long way to go. But it's not really, the H word isn't being quite really bandied about in the States. There's currently a lot of transmission in many parts of the country, so it is patchy, that's true. Vaccines will help decrease that. So here's a frank admission here from Dr. Carlos de Roy, Emory University School of Medicine. Not familiar with it, but vaccines will help decrease that. Vaccines will help decrease transmission, and of course, everyone knows this. Just that people seem strangely reluctant to admit it. He says, get vaccinated as soon as you can and help control this pandemic. So that makes sense to me. Now, National Institutes for Health, Francis Collins, famous scientist, physician, highly qualified, of course. Allow more time for scientists to investigate the links between vaccines and blood clots. This is talking about the Janssen, Johnson & Johnson, and whether certain groups of people are more susceptible. Now, this is interesting because remember there was, now let's get my memory right here, there was 6.8 million doses, wasn't there, given. And there was 6 cases of these cerebral sinus venous blood clots. So that works out about 1 case in 1.2 million. So that's what he still wants to be investigated. But yesterday we looked at this data for the incidence of portal venous thrombosis after the Pfizer and Moderna vaccines, and that's 44 per million. So they don't seem concerned about 44 cases per million of blood clots that can form in the portal vein, which can be fatal from people, at least it can be fatal in people that have had COVID. But they do seem concerned about 6 cases in 6.8 million. 1 case in 1.2 million seems to be a concern. 44 cases per million doesn't seem to be a concern. Now, we're not saying vaccines are without risk. We know they're not without risk, but we know the efficacy and the need for vaccines is in the view of all the authorities overwhelming. But it just seems a bit of an inconsistency there. So 44 per million, not a problem. 1.2 or 1 per 1.2 million, like 45 times more or something, I don't know, 48 times more or something, is an issue that needs to result in vaccine pausing and suspension. Great thing about the Janssen vaccine, of course, is I think it's $10 a shot, and you only need 1 shot, and it's transported in a fridge, and that's good. It's like the AstraZeneca vaccine. I think that's $3 a shot, so they've agreed not to make a profit on that one, and the profit on the Janssen one must be pretty low if it's $10 a shot. So if you think about it, to be vaccinated with the Pfizer, the Oxford AstraZeneca, 2 doses at $3 each is $6. To be vaccinated with the Janssen, Johnson & Johnson, 1 dose is $10. Anyway, I'm sure that's nothing to do with the pausing. Right. Lots of questions on this Indian double mutant variant emerge. I haven't got this chap's permission to use his name, so I'm not going to tell you who he is, but he is in the comments. Thanks for the update. I'm from Delhi, India. I've contracted the virus, so we wish you all the very best. We really hope you make a good recovery. Situation in India is very bad. Most of the hospitals are already exhausted and many people are dying without treatment. Can't verify that, but I don't see why he should be lying to us. Cases in India now well over 200,000 per day. So this is the 200,000 per day line here. There's the 200,000 per day line, and as you see, we're well over that, and unfortunately that only seems to be going in one direction. And I know from talking directly to healthcare colleagues in India, they are concerned and already very, very stretched. Now, this so-called double mutation or double variant, whatever you want to call it. Now, this is now called the India variant. So obviously we've had the variants that have arisen in South America, Brazil particularly, actually it was, South Africa, the UK variant, I'm afraid we know all about. California variant, there's been 2 of those. New York variant, there's been 1 of those. Now there's an India variant. We seem to name these variants after where the virus variant was first emerged. India variant is B1617. Now, there are 2 mutations on the spike protein. Now, that's the 484th amino acid in the spike protein. That's the 452nd amino acid in the spike protein. That means the E amino acid has been changed to the Q amino acid, and that means the L amino acid has been changed to the R amino acid. So we do see that there are two changes to this spike protein, which is on the surface of the coronavirus, because we know it has these infectious spikes. And we know it's these that fit into the receptor sites on your cells to give the human being, that would be the human cell there. And if this is fitting on better, and especially in this area called the receptor binding domain, then obviously the virus is getting a better grip, so the RNA in the virus can be more successfully injected into the human cell to cause the infection. So that's why it's a double mutation. It's both of these. Now, first reported in India late 2020, Indian Council of Medical Research has not been stamped as a variant of concern, so as to say that it's more lethal or more infectious. So he's saying there's no evidence that it's more lethal or more infectious. But I think he's putting a bit of a sunny gloss on that. So I've put there but, and it's a pretty big but. There was a very low prevalence of this in January. Now, this is from Outbreak Tracker. It's quite hard to get the information on this, but have a bit of a look around. You'll find it in there. Very low prevalence in January. So it just seemed to start last November, December. And now very low prevalence in January. But April, 52% of the national sequencing. Now, in India, the national sequencing level is fairly low. Last year, it was about 1% at the end of last year. They're building it up now, and they're hoping to build up to 5% of all the positive cases diagnosed are going to be sequenced. So that would be quite good if it gets up to 5%. But at the moment, it's still fairly low. And I just want to show you something else about India here. If we have the technology, we do. This graphic here is showing these are the new cases in India per capita, and we see it's rising quite markedly, where we see the UK is falling. So we can see the cases in the UK are there about 25 per million. In India it's about 140 per million, so that's going up. But how accurate is this figure? To get that, we've got to look at the testing. And there we see the testing in India. So the samples tested are remarkably low. It's about 1 per 1,000 people, whereas in the UK it's about 14. So this means that the infection in India compared to the UK, I think we can say that fairly accurately, the infection in India compared to the UK is greatly underdiagnosed, whereas in the UK the level of testing facilitates better diagnosis. So does that mean that the cases in India are way, way higher than that? Well, it certainly means they're a lot higher than that, yes, because a lot of people in India are not do not enjoy the testing facilities that we enjoy in the UK. Now, getting back to this double mutation, Maharashtra state, 60% of cases now. And bear in mind that's only about a 1.5 to sort of 2% level of testing. The genomic testing of positive cases. So basically we're not sure, but it does seem to be getting higher. This Indian mutation has been detected in 10 other countries, the United States. Why are we still flying around in this pandemic? This is a potentially really dangerous variant in India, and it's potentially causing this massive increase in India. And United Kingdom, there's been 77 genomically diagnosed cases from India. Now, as far as I know, these are still in quarantine, but even so, why are we taking these kind of risks? There's been cases in Australia and New Zealand which are both in quarantine from India. Now, we did mention this is a double mutation. And the Indian Council of Medical Research say they don't know much about it. So they say. But this L452 mutation, which of course is this one, has arisen independently. That one has arisen independently in the United States. So it's arisen in India, but independently it had previously arisen in the United States, where it has been actually quite well characterized. And just that one mutation alone in the United States, from US data, 20% more transmissible and reduces antibody efficacy by more than 50%. So it looks like 20% more transmissible just with that mutation, just with that one. But the extent of the double whammy with that one on that and that one together, we basically don't know how they double whammy. How do they inhibit each other? Do they synergistically potentiate each other? We don't really know. But we do know that single mutation, the 452, 20% more transmissible in the States, reduces antibody efficacy by more than 50%. How does it evade the other cells of the immune system? We don't know, because it's easy to do the experiments on the antibodies. Well, relatively. Not for me, it's not, but for the people that do this, it's relatively easy. To do tests on things like memory T cells is much harder. So will this mean that some people are getting reinfected? Well, it's going to increase the risk of reinfection. I think we can say that. So it is the Indian situation is a concern. William A. Hasseltine, former professor at Harvard Medical School, agrees the B167 variant has all the hallmarks of a very dangerous virus, says the professor. We must do all that is possible to identify its spread and contain it. So, yes, absolutely. So, I was going to go. I would lose track of time on these things. I was going to go on and do Chile, but I think we'll leave Chile for now because it's a bit of a complicated story. A lot of you have asked me questions about it. Maybe we'll just finish off. We'll do Chile in a bit more detail tomorrow because you have to be fresh for that one. It is a bit complicated. But Brazil seem to have run in areas. Did you know? Seem to be running low on sedatives. Healthcare workers forced to intubate patients. Where's my drink? I haven't got it. Healthcare workers forced to intubate patients without sedatives. This is pretty frightening. Mechanical restraints and neuromuscular blockers. So patients can be mechanically restrained. We believe this is happening. And they can be given muscle relaxants, but of course they won't knock them out. They will still be conscious. This is a pretty frightening report. This is, I think the Washington Post picked this up from Reuters, I believe. So shortage of sedatives in some areas of Brazil, that is very, very concerning. Doctors Without Borders have reported more than 12 months into Brazil's COVID-19 emergency, there's still no effective centralised and coordinated public health response to the outbreak, according to Doctors Without Borders. The lack of policy, the lack of political will to adequately respond to the pandemic is killing Brazilians in their thousands. This is just... Deaths are one thing. Preventable deaths are something else, and it really is. It's just tragic to read that deaths could have been prevented with more anticipation and proactivity. Okay, well that'll do us for today. I think you'll agree that they're quite significant points for the future of the next few months. And we'll look at the Chile situation hopefully tomorrow. And I'm just reeling at that thing I've just read from Brazil. It's just so terrible that people are dying unnecessarily. Okay, that'll do us for today. Okay, and as always, of course, thank you for watching.